it enables us to provide holistic care to the client. It works really well together because even if you are a client who has diabetes or are a high falls risk, you would benefit from exercise, but you would also need mobility aids. You also might have acute musculoskeletal conditions. And if you are overweight, you would benefit from advice on diet from a dietitian. So it doesn't, narrow-sightedly narrow down what someone's needs are. It enables us to refer to each other rather than referring externally. It also enables us within a multidisciplinary team to create programs that are multidisciplinary as well. So things like pulmonary rehab, cardiac rehab, groups to maintain cognition. We can get OT input, we can get input from a speech therapist, we can get exercise professional guidance and input from myself for falls prevention. Rather than just going, you've got memory loss, let's just give you an assessment from an OT and shut the door. It's just so important, and it enables you to develop as a clinician because you then have a greater understanding and appreciation of other disciplines and how they work within the healthcare system. But like I said, very fortunate. There's a wide array of clinicians, a wide array of experience, and that also enables groups to be delivered effectively based on the client's healthcare needs.
In my life as a public health physiotherapist, depending on the area that you're working in, you might have daily interactions with an interprofessional team, or you might have weekly interactions with a professional team in terms of meetings. But on the ground, on a typical day on an ICU ward, where I spent a lot of time when I was at the Prince Charles, you do a ward round in the morning with the consultant, the registrar, the residents, the pharmacist, the physios, the OTs, the dietitians, the podiatrists, the speechies. So you'd have 10 to 20 people at each bedside, all contributing towards the care of a patient. So you'd have a summary, and then everyone would get an opportunity to discuss what they thought was most important for that client at that time and what they needed at that time. And it would take anywhere from 15, 20 minutes to an hour to get through 10 beds. But that level of coordination in a team was really important, especially in that really acute phase. When things change quite quickly, it's really important to make sure that everyone's on the same level and that everyone is aware of the intricacies of someone's care.
I think some of the disadvantages of working in an interdisciplinary team is that sometimes it can be a slow, frustrating process because people have different opinions, and those opinions will sometimes clash. And then also there's timetabling issues, especially working with vulnerable people, because they're not always clear on their timetable or what's happening. So often we found there were timetable clashes, and so it required a lot of flexibility and grace, I think, on behalf of each of the team members to realise that we were working in a vulnerable type of context.
So we have psychologists, dietitians and exercise physiologists. Generally, the psychologist is the one that does the intake and the assessment and the treatment planning, and then might sort of develop a treatment plan with the client and look to where a dietitian or exercise physiologist may be of help, not always. And then how we collaborate is the team all have one-on-one supervision with myself, but we also have a meeting once a week that's like a case review of all of our cases. We have shared case notes, which obviously clients know at the outset, and that's made very clear when we sort of get their informed consent. And actually all of our clients as well get a treatment folder, and they're really encouraged to take that folder to every appointment within this session and any appointments outside of here as well. So their GPs or their psychiatrists can see what they're doing in session, and they can add their medical monitoring or their Medicare mental health care plan updates to that. So we kind of use the folder as well as a way of communicating between all of us. when we do get a referral from a practitioner that's external to this practice, our reception team will triage the referral, and then they'll contact the referrer and let them know this is the outcome, this is the clinician that they're going to be seeing, this is the date, and then the practitioner will follow up. So straight away the referrer knows what's happened to their client and what their treatment's going to be. And then once the full assessment's been done by whoever the client has been allocated to, they then provide a report and a treatment plan to that referrer as well. So they know what that practitioner has sort of assessed and what their plan around treatment is. And then we provide updates at the 6 and 10 sessions, which is the Medicare requirements, as well as needed. In order for us to accept a referral as an outpatient private practice, we ask that the GP agree to do weekly medical monitoring until the condition improves. And so we'll be contacting the GP every week if we haven't got those updates around the client's medical monitoring. And we'll be saying to the client, you can't come back for your next session until you've been back to the GP and had clearance to continue treatment in an outpatient setting. So particular eating disorders, there's probably weekly contact between us and the main medical practitioner to make sure that the client isn't deteriorating medically and should be better treated in, say, a hospital inpatient setting.
The best example of collaboration for me was my previous job at Disability Services in Nunda. So we worked with children who were 0 to 5 who had complex and multiple disabilities. I worked in a team where there was speech pathologists, where we had occupational therapists and physios, we had a social worker on our team, we had a psychologist on our team, as well as a couple of case managers whose job was to help bring us all together and to have that collaboration. And all of our work, right from when we first met with a family, was all about that collaboration. So our team was the person with a disability, their family, and then us around, all holding together and working together. So we would set goals with a family based on that family's needs and based on that family's priorities. And we would work in a way to help that family develop their capacity and to help them support their child to develop to the very greatest extent that they could. And because we were working with complex kids in complex environments, we needed each other's perspectives